Thank you very much for joining. This is the April 4th webinar of the Council of State Governments Eastern Regional Conference. I'm Ellen Andrews, consultant to the Health Policy Committee, and I'm joined by committee co-chairs Paula Roy of Delaware's Healthcare Commission and Representative Betsy Ritter, who is co-chair of the Public Health Committee in Connecticut. We're fortunate to have Stan Dorn, Senior Fellow at the Urban Institute, with us today to talk about the basic health program option for states under the National Affordable Care Act. Stan is an expert on the Patient Protection and Affordable Care Act, Medicaid, the Children's Health Insurance Program, CHIP, federal programs to subsidize coverage for laid-off workers, and strategies to maximize coverage among individuals who qualify for subsidies. Among the states he's advised on health coverage include a good number of our Eastern region states. They include Connecticut, Louisiana, Massachusetts, New Jersey, New York, Maryland, and Washington. Before Urban, Mr. Dorn was Senior Policy Analyst at the Economic and Social Research Institute, where he focused on bipartisan strategies for national health reform, Director of the Health Consumer Alliance, a consortium of legal services groups that help low-income Californians obtain health care, Health Division Director at the Children's Defense Fund, which is when I first met him, and I think his first trip to Connecticut, where he led the organization's health policy team in a national campaign that helped pass CHIP, and managing attorney of the National Health Law Program's Washington office. He's a graduate of Harvard College and the Bolt Hall School of Law at the University of California at Berkeley. Some housekeeping for the webinar. If you're listening on the phone, remember to input the audio pin. That should be visible on your screen if you want to be able to talk and ask questions. We'll be keeping everyone on mute, including myself, until Stan is finished, and then we'll have some time for questions. To ask a question, you can raise your hand by clicking on the little hand in your screen, or you can type your questions into the question pane text box on your screen at any point in the webinar. And slides from this webinar will be posted on CSG ERC's website soon at www.csgeast.org. So I will let Stan get started.
Thank you very much, Ellen, and I really appreciate the opportunity to chat with you folks today. It looks like I have mouse control. Do I have mouse control? Here we go. All right, we'll give it a shot. I'm going to talk about three things over the next few minutes, and then I'm hoping we'll have a chance to have some vigorous back and forth. I'm going to talk about the federal law that pertains to the basic health program option, what some different choices are that states could implement, and some issues for consumers and for states. But before I get into any of that, I'd like to, let's see, first of all, make sure, oh, here we go, I got it. But first I wanted to talk a little bit about affordability, because part of what's motivated this analysis of the basic health program are some concerns about the affordability and coverage in the exchange, notwithstanding the federal subsidies that are made available under the Affordable Care Act. Obviously, those subsidies will make coverage a lot more affordable for low and moderate income people without access to employer-sponsored insurance. But even with the subsidies, as this slide shows, the cost could be more than many would be able to afford. So, for example, at 150% of the federal poverty level, and this is using 2010 FPL levels, people with $1,300 or so in monthly pre-tax income would be asked to spend more than $50 a month for premiums. That's a fair bit of money in a very limited household budget. $1,600 a month, people would be spending $80 a month in premiums out of that pre-tax income. So it's a significant amount of premium costs. Now you may notice the column on the right about actuarial value. What that refers to is the percentage of healthcare costs that are paid for a standard average population by the insurance company. So there are lots of different ways you can structure actuarial value. You can have high premium, you can have high deductibles and low cost sharing, low co-payments. You can have high co-payments and low deductibles. But the bottom line is, however you combine the out-of-pocket cost sharing rules, it has to result in the insurance company, the insurance policy, covering 94% of all costs if you're somebody at 150% federal poverty level, and 87% of all costs if you're above 150 but at or below 200% of the federal poverty level. So what would this mean? Well, here are a couple of examples. The first row shows average employer-sponsored insurance according to the Congressional Research Service, average employer-sponsored HMO coverage. This is what people with incomes below 150% of the federal poverty level could get. under the Affordable Care Act. And that would mean $20 office copays, and notably $10, $25, and $45 copays for prescription drugs, depending on whether they're generic, on the formulary, or off the formulary, and name brand drugs. It's a very middle-class type package, and there's a serious question about whether low-income people can afford those kinds of copays. The cost-sharing rises even more for people above 150% of the federal poverty level. The second row shows what coverage looks like for the federal Blue Cross Blue Shield plan, which the Congressional Research Service estimates to have an actuarial value of 87%. $250 individual deductible, $15 office copays, and then 25% of whatever the face value, the face cost is of prescription drugs can get quite expensive. And we know there's a lot of literature that's been done, a lot of research that's been done about the effect of copays and premiums on low-income people's enrollment into coverage and utilization of services. And there's a good chance that for many low-income people receiving subsidies in the exchange, these costs would be would deter enrollment into coverage for some, and many who receive coverage would delay using their insurance until they get very sick, and such delays can have clinically measurable effects, adverse effects on health status. So those are some of the concerns about affordability. The other issue in the exchange is that the premium subsidy comes in the form of a tax credit, which is advanced to insurance companies as monthly premiums become due. And the size of the credit is based on your income. The higher your income, the lower the credit. But your income is estimated as of a point in time when you apply for benefits. If at the end of the year your income turns out to be lower than what you thought it was going to be, you get an extra extra credits, extra tax credits at the end of the year in the form of an increased tax refund. However, if it turns out that you got a raise that you didn't expect, or a Christmas bonus, or somebody in your family got a new job, or somebody died, and therefore the family size is smaller, and therefore the percentage of poverty is higher. Under any of those circumstances, if it turns out that the amount you receive during the year in tax credits exceeds the annual amount based on what your year-end annual income is, then you have to pay the IRS back the extra credits at the end of the year, which can eliminate your tax refund. Tax refunds are something that a lot of low-income families count on at the end of the year, or you may wind up actually owing money to IRS. Now, this slide shows you what the current maximum amounts are that can be expected from tax credit recipients. So if you're a low-income person, you can only be required to pay back, say if you're a family below 200% of the federal poverty level, $600 is the maximum. Well, that's a considerable chunk of change for a low-income family, but at least there's a limit. What you should know is that this slide shows the current levels, the current maximum safe harbor amounts. These are higher than they were when the bill passed. These amounts were increased to pay for the Medicare, so-called Medicare doc fix, the increase in payment rates for Medicare docs. There's now a proposal, it's passed the House, on the Senate floor, that would once again raise these amounts, this time to pay for the so-called 1099 fix. There's a requirement in the health reform law that says that small businesses have to send 1099 forms to report any contract or expenditure of $600 or more. A lot of small firms have complained about the paperwork implications, but eliminating it would cost money because it would be harder for IRS to detect tax evasion, and so it needs to be paid for. And the way that the House proposed to pay for it is by further lifting these caps. And the concern is, obviously, as time goes by, this is a convenient piggy bank. And even as is, I'm worried that a lot of low-income people may fail to take advantage of tax credits because they'd be worried about what they might owe IRS at the end of the year. We've seen a similar effect happen at the EITC, the Earned Income Tax Credit, where less than 3% of Earned Income Tax Credit beneficiaries take their credits in advance during the year. And one big reason is they're worried if their income turns out to exceed the estimated amount, then at the end of the year they may lose their tax refund, they may owe money to IRS. We could see something very similar happening here. And as I say, these are the current maximums, and those may rise further in the future as Congress looks for more ways to break open piggy banks and use the money for all kinds of good things. So those are some of the concerns. And the advantage of the basic health program is, depending on how states do it, they could escape some of these issues that are going to face low-income consumers. So let's talk about what the federal law provides. Certain people qualify for the basic health program. You have to be under 200% of the federal poverty level, ineligible for Medicaid, CHIP, Medicare, citizen or legally present immigrant, and you have to have no access to affordable, comprehensive, employer-sponsored insurance. And basically what it means is you have to be under 200% of the federal poverty level and somebody who would qualify for tax credits in the exchange under ordinary circumstances. Or another way to put it is basically we're talking about two different groups of people. We're talking about adults between 133 and 200% of the federal poverty level. As you all know, beginning in 2014, under the Affordable Care Act, Medicaid coverage is going to go up to 133% FPL, federal poverty level, for all adults. But above that amount, between 133 and 200% FPL, these adults can qualify for the basic health program if that's something that the state decides to do. The second major group consists of immigrants under 133% of the federal poverty level, legally present immigrants who are ineligible for federally matched Medicaid, most often because they've arrived in the U.S. within the past 5 years. There's an option under CHIPRA, the new Children's Health Insurance Program Reauthorization Act that passed in 2009. There's an option for states to provide coverage to children and pregnant women who've been recently legalized. There's no such option for other adults. And regardless of what choices the state makes in terms of implementing that CHIPRA option, whatever immigrants who are under 133% FPL, ineligible for Medicaid, but are lawfully present, they could go into the basic health program. And then finally, as I think most of you probably know, the CHIP allocations, Children's Health Insurance Program allocations, are currently in the law only through 2015, through the end of federal fiscal year 2015. If Congress fails to add new CHIP allocations after that year, then eventually the current allotments will end, and CHIP children would be put into the exchange. Those CHIP children above 133% FPL and below 200% FPL could instead go into the basic health program if that's something the state wants to do. But that's not going to be a real live issue for folks until after 2015, and it may never be a real live issue if Congress adds more money to the CHIP program. So those are the people who can go into BHP. What happens to people who are on BHP? Well, you're not in the exchange anymore if you're in BHP. It's not a choice. The state says, here you go. And where you go is into a plan or provider that contracts with the state to take care of BHP consumers. There are certain minimum requirements under federal law that these plans or these providers must fulfill. They have to cover at least all minimum essential benefits. Premiums may not exceed what would be charged to these low-income consumers if they would be covered in the exchange. And actuarial value must meet certain minimum standards. Now, this is the floor. It's not the ceiling. There's nothing that bars a state from giving more generous coverage, richer benefits, or fewer costs for consumers who are in BHP. So a state could, for example, base its BHP coverage on the level of protection currently furnished by Medicaid or by its CHIP program. Now, those are the services that are offered. What's the funding stream? The federal government pays 95% of what it would have spent for these basic health program folks through tax credits and out-of-pocket cost-sharing subsidies in the exchange. The federal dollars go into the state trust fund. The state has to set up a trust fund dedicated to using these dollars for BHP enrollees only. States can't use these funds for other worthy purposes, building stadiums, etc. So that's in a nutshell what the federal law provides. What are some options that are available to states? I'm not going to discuss in these next few minutes all of the different options. There's obviously a huge range of choices that states could make. What I'm instead going to do is focus on using existing programs to make coverage more affordable. A couple of different ways states could do that. And the reason why I'm focusing on that is twofold. First, as I mentioned earlier, part of the motivation behind the basic health program is to find a way to make coverage more affordable to near poor state residents, more affordable than the coverage is slated to be in the exchange. But the second issue is states have a lot on their plates right now in terms of getting ready for 2014. And, in theory, a state could create a brand new program, inventing new benefits, cost-sharing rules, and so forth from scratch. I'm assuming that's going to be a pretty heavy lift right now. And therefore, it makes some sense at this point for states to think about using their existing programs as a template on which to build for this new population. So looking at just those kinds of proposals, those that you build on existing programs to make coverage more affordable to low-income adults, there are 4 approaches that one can think about. First would be Medicaid look-alike coverage, where the adults get the same benefits that they would get in Medicaid, the same premium and cost-sharing amounts. They would be enrolled in the same health plans. As far as the adults are concerned, it would be just the same as Medicaid, but behind the scenes, the arrangements would be very different. It would be the federal BHP dollars equaling 95% of what the feds would have spent in the exchange. It's a different federal statutory scheme. Something very similar to this happened when the Children's Health Insurance Program was established in '97. Some states said, we're going to take this money, we're not going to make it an individual entitlement, but we are going to offer the exact same kind of coverage that we do through Medicaid. So from the family's perspective, it was the same benefits, same costs, same health plans. They didn't know there was any difference, but back in the back room, there was a different accounting, a different set of federal dollars coming in the door, a different underlying federal statutory scheme. So you could do something similar here. A second approach would be you could say we're going to essentially take our CHIP program and make it for adults as well. This is in a state that uses CHIP to provide coverage to somewhat higher income children with some premium costs, some out-of-pocket cost sharing that go beyond what's charged in Medicaid, and potentially some benefits that are a little bit less than what's charged in Medicaid. I don't know to what extent the folks on this call have programs like that. But in states that do, one option that they could think about is to say, well, maybe we should essentially take our CHIP program and say we're going to open it up to adults as well, so that it would still be a heck of a lot more affordable than coverage in the exchange. But as income rises above 133% FPL, the amount that consumers would be expected to pay would also rise. And that may have some appeal in some states, depending on sort of what people's political philosophies are. A third approach would be to say, you know what, let's take this basic health money and Medicaid and CHIP and put it all together to implement one integrated program that serves everybody in the state up to 200% of the federal poverty level, where it's affordable. Maybe there's a sliding scale. Maybe as income rises, the costs go up somewhat, but they certainly wouldn't be as high as would be charged in the exchange. That presents an opportunity for rebranding, just as many states rebranded their Medicaid programs when CHIP came along and said, Connecticut, for example, it's Husky. Even before CHIP, Vermont provided an example of Dr. Dinosaur. This may present an opportunity for states to say we're going to rebrand our Medicaid program, try to increase its appeal, call it whatever you call it, and from the family's perspective, wouldn't matter. Same plans, maybe you pay a little bit more as income goes up, but it's just one program. Behind the scenes, you would integrate the CHIP dollars, the Medicaid dollars, and the BHP dollars. The fourth and final option that I'll mention is a two-way bridge, where BHP consumers could be allowed to choose between Medicaid plans and exchange plans. This offers, increased choices. It means the people to whom lower Medicaid costs are more important could pick a Medicaid plan. The people to whom greater access to broader provider networks could pick a private plan. It would let people retain private coverage if their income drops below 200% FPL, retain Medicaid if their income goes over 133% FPL. A lot of appeal to this option. However, there are some challenges that would arise. There would be very teeny groups in a lot of these plans, so the state would have to work very hard to implement mechanisms to protect these plans from unforeseeable claim spikes. And there also would be issues about risk sorting. Some types of consumers might disproportionately pick one plan, others might pick another. So you need to work pretty hard on that. The other concern with the two-way bridge is that consumers could get awfully confused. I mean, it's confusing enough for many consumers to pick between a bunch of Medicaid plans or a bunch of private plans. But to offer a broad range of plans with two different subsidy systems, it could get very confusing. And we know from the literature that when consumers are offered these kinds of confusing choices where there's a lot of apples and oranges in play, people sometimes just shut down and they delay making the choice in plan, or they don't ever choose a plan. So there'd be some challenges in communicating with consumers. So each of these options has its advantages and its disadvantages, but they all share the common feature of making coverage much more affordable to low-income consumers and avoiding the risk that people would have to repay IRS at the end of the year if their income turns out to exceed projected levels. Now, moving on to what some issues are. One key question is the finances. And so my colleagues here at the Urban Institute who do microsimulation modeling estimated what the average federal BH payment would be compared to the average cost of covering a BHP-eligible adult through the Medicaid program. And what they found was, as you can see, that in the average state, federal BHP payments will be 29% higher than average Medicaid costs. Now, how on earth can this be? Well, the reason why that's the case is that provider payment rates are much higher in private insurance than with Medicaid. And the federal BHP payment is 95% of the premium subsidy, which is based on private insurance costs, plus a 95% of the out-of-pocket cost-sharing subsidy, which is also based on private insurance costs. If you were to put aside BHP and just look at how much does it cost for Medicaid to cover somebody versus how much does it cost for private insurance to cover somebody, if you control for health status, the differential is quite stark. If you look, for example, at the working poor population, which is most analogous to BHP, Medicaid costs are on average, well, excuse me, private costs are 29% higher than Medicaid costs. So this is really not a big surprise in terms of how it would work out in the average state. Now, each individual state is going to have its own unique situation, but on average, states would get more from BHP than it would cost them to provide Medicaid. Now, all of this assumes that the distribution of private insurance premiums in the exchange is going to be similar to what it is today. Some differences, greater efficiencies, and so forth, but that by and large it'll look pretty much like private insurance markets look today. That's very important because the tax credit is pegged to the premium cost of the reference plan. In other words, it's the second lowest cost silver plan, the second lowest cost plan with an actuarial value of 70%. And if the reference plan is typical of what you'd expect in private insurance markets today, then the numbers I just provided will be accurate. However, if the reference plan is higher, then the federal BHP payment will be higher. If it's lower, the federal BHP payment will likewise be lower. So, for example, if the reference payment is a very inexpensive Medicaid plan, then the tax credit amounts will be much lower than we've projected, and therefore the BHP payments will be much lower. Or if the exchange does an extraordinary job lowering premiums through aggressive negotiations with insurers, and the effect is that the reference premium is much lower than one would expect, then the state BHP payments will likewise be lower than what one expects. So a very important factor influencing the amount of the federal BHP payment will be the way the exchange is organized and run and how effective it proves to be in reducing premiums. So let's talk for a moment about what some of the state cost savings might be under the basic health program. The idea would be if you have adults with modified adjusted gross income above 133% of the federal poverty level, they could be shifted from Medicaid into BHP. And that would mean that instead of the state having to pay 50% of their costs or somewhat less, depending on what the federal matching rate is in your state, instead of the state paying something for their costs, the state would pay nothing because it would be federal BHP dollars that would be paying for their coverage and care. So who are we talking about? Well, in almost all states, pregnant women are covered above 133% of the federal poverty level. In many states, parents are covered. Sometimes others are covered. And keep in mind that the way income will be calculated in the new world will be different than the way it's calculated today. It'll be modified adjusted gross income, which means adjusted gross income for tax purposes plus tax-exempt interest plus tax-exempt foreign earnings. So there are some people who might be covered as parents today, classified as having income at 100% FPL, who under the new MAGI rules would be classified as having income at 150% FPL. Now, come 2014, states will be able to eliminate optional coverage for Medicaid adults above 133% of the federal poverty level. The exact same savings could be achieved by eliminating these adults' Medicaid coverage and moving them into the exchange. However, doing that would not save any money for the state beyond BHP implementation, and it would expose these adults to potentially much higher costs for premiums and out-of-pocket cost sharing and the risk of owing money to IRS at the end of the year. So in other words, the only way that states can save money on these near-poor adults and prevent them from experiencing increased costs is for the state to move them into BHP with coverage modeled basically after Medicaid or after the state's CHIP program, instead of moving them into the exchange where, yes, the state would save money, but these adults might experience much higher costs and would face the risk of owing money to IRS at the end of the year. So that's one area of state savings, eliminating Medicaid eligibility for folks who move into BHP. A second area involves the medically needy, and this is for states that have spend-down coverage, where the spend-down period varies from 1 to 6 months. But the idea is, after I'm somebody who doesn't have any other coverage, I'm uninsured today, and once I incur a certain level of expenditure of health care costs that reduces my remaining income to a specified level, from that point forward, any remaining health care costs during that spend-down period are covered by the Medicaid program. So for many people, this covers long-term care. For some people, it covers a catastrophic cost. I'm a medically needy person. I get hit by a car. I wind up in the hospital. Those expenses reduce my remaining income below the threshold level, and then Medicaid steps in and pays all the remaining costs. Or certain chronically ill folks, people who aren't sufficient, who may not get SSI, supplemental security income. Maybe their income's too high for that, but they have serious health problems, and every month they incur expenditures, and so after they incur a certain level of expenditures, their health care costs for the rest of that month or the rest of the 6-month period are picked up by the Medicaid program. That's how medically needy eligibility works. Once coverage extends, once comprehensive insurance coverage becomes available up to 400% of the federal poverty level under the Affordable Care Act starting in 2014, states will save money, potentially a significant amount of money, on their medically needy programs. That's because folks who formerly were uninsured will now have comprehensive coverage, and that means it will take them much, much longer to meet their spend-down requirements. In other words, if today I have to incur $100 in expenses in a month before I qualify for Medicaid for the rest of the month, now it's pretty easy to do. Say I'm somebody with chronic illness, a couple of prescriptions, I hit the $100 limit. From now on in, the Medicaid program picks up my costs. Well, once I have comprehensive coverage, then maybe instead of paying $50 for a prescription, I just pay $10 for that prescription. And so during the entire month, I have a couple prescriptions. I never meet my spend down, or I only meet it during the months when I go to the doctor, or I wind up going to the hospital or something like that. So with comprehensive coverage, a state's medically needy expenses are likely to decline, potentially significantly. Basic Health offers the additional option of letting a state structure this coverage to make it even slower for somebody to meet their spend down. So obviously, if there are lower out-of-pocket costs, that means it takes a longer period of time before that person meets their spend down, incurs medical bills that they have to pay for. And that would be the natural result of modeling BHP benefits off Medicaid benefits or CHIP benefits, lower out-of-pocket cost sharing, therefore takes you longer to meet your spend down, therefore more savings for the state. But also, a state could consider looking at providing more long-term care coverage for BHP than would normally be offered by standard private insurance, and that could further delay the point at which some people meet their spend down and further increase state savings. So there's some interesting opportunities here. The final group that I'll mention is legally present immigrants who are ineligible for federally matched Medicaid. There's some states that provide coverage to these folks, either entirely at state expense or taking advantage of some federal options to provide coverage, and these people could be moved out of state-funded Medicaid and into what would seem to them to be the exact same type of coverage, same benefits, same costs, et cetera, but it would be funded by the federal government through the Basic Health Program. So those are some of the areas of possible state cost savings from implementing BHP. Now, one big concern that people raise is, well, what will this do to the size of my exchange? And will this make my exchange so much smaller that it becomes destabilized? The answer in most states is no, will not reduce your exchange to the point that it becomes destabilized. In the average state, what it will do if you implement BHP is instead of the exchange covering 8% of residents through the small group market and 8% of your residents through the individual market, your exchange would cover 8% of your residents through the small group market. BHP doesn't affect the small group, and 6% of state residents rather than 8% of state residents in the individual market. So it would shrink some. It would shrink from 16% of state residents to 14% of state residents, but it would certainly not be a catastrophic impact on exchange size in most states. It's going to vary a lot. In West Virginia, it may be a very different picture because of a much larger low-income population. But in terms of a national average, it's not going to be a devastating blow. It will be a bit of a shrinkage, to be sure. And so that means a couple things. One is it means that there's a little shift in leverage from the exchange to state purchased coverage to the extent that leverage gets used to lower costs, what it means is that instead of any cost savings accruing to the federal government in the form of lower premium subsidies, cost savings, to the extent they exist, would accrue to the state in the form of lower costs for state-sponsored coverage. But that's more speculative. It depends on what approach a state takes. Is a state using is it putting together all the different categories of state purchase coverage to try to leverage better prices? Some states are doing that. Many are not. And so that will vary a lot by state. But what will not vary is that fixed administrative costs for running the exchange will be spread over a smaller population, and that means that the unit costs will go up somewhat, not disastrously, but definitely somewhat. And that's a downside risk one needs to be aware of. Speaking of risk, a question that many have asked is, well, what's going to be the effect of BHP implementation on the risk level of people in the exchange? And it's an important question. Let me describe to you how we analyze the issue. What counts is not the effect of BHP implementation on risk level in the exchange per se, because the Affordable Care Act works very hard to pool together all individual coverage, so that the relevant question is, what's the effect of BHP implementation on the entire individual market in the state, both within the exchange and outside the exchange? As I'm sure most of you know, the Affordable Care Act says that that insurance companies have to pool all their individual market enrollees together, both inside the exchange and outside the exchange. And the premium that they charge in the individual market has to reflect that combined risk pool. In addition, if one particular insurance company winds up having a lot of high-risk folks, there are mechanisms in the Affordable Care Act, risk adjustment mechanisms, which are ongoing, and temporary reinsurance and risk corridor mechanisms, which try to share the risk, so that if I run a plan that suddenly has a lot of high-cost folks, and you run a plan with a lot of healthy folks, well, through the risk adjustment process, I'm going to be essentially turning money over to you, so that I'm running the high-cost plan. You're going to give me some money, so that you don't experience a windfall from having a lot of healthy people, and I don't experience an adverse impact of having a lot of sick people. So through these mechanisms, all of the individual market is supposed to be pooled together. So the question would be, okay, if we take the BHP folks out of the individual market, what happens to the average risk level, and therefore to the average premium inside that remaining market? If the effect is being experienced by the individual market as a whole, it is obviously going to have a smaller impact on premiums than if the effect were experienced just by the exchange. So that's something to keep in mind. Second point is that it's going to vary by state. And it's also going to vary not just based on state demographics, but also state policy choices. So, for example, if a state merges the individual and the small group market, then the individual market becomes more than 15% of the state population. And implementing BHP would have a de minimis effect on that entire merged individual market. The second piece to keep in mind is if a state cuts back its Medicaid eligibility above 133% FPL, then the VHP population will have those Medicaid folks in it. And in many states, it includes those Medicaid folks include pregnant women who cost a lot of money to care for, and many people with disabilities or serious health problems. So it will vary by state, but our sense is in many states, if they eliminate Medicaid coverage above 133% FPL, or otherwise try to shift Medicaid costs to federally subsidized coverage, BHP implementation might not affect the net risk level in the exchange and in the individual market, or it might actually improve it, depending on the state, because it would pull relatively high-cost folks out of that market. So remains to be seen. The final piece I wanted to mention is that there may be a state policy option to further reduce the risk effects of BHP implementation. And the idea behind the state policy option would be essentially to keep BHP part of that huge merged individual market, so that implementing BHP just means that people move from one plan to another inside a broad, collectively risk-shared market, rather than leaving the market entirely. So how would you accomplish that goal? Well, what would you do? A couple things. One is you'd say, we're going to include BHP in our reinsurance mechanisms, which are state-administered, and our risk adjustment mechanisms, which are also state-administered, so that if BHP has a lot of sick people, then it'll get money from the individual plans. If BHP has a lot of healthy people, it will give money to the other individual plans. The second piece would be if a BHP plan is a state-licensed insurance plan that serves others in the individual market, a state could say, BHP individual market plan, you have to pool risk together with your other individual market enrollees. Now, we have not received a definitive interpretation from federal officials about the permissibility of this approach, but the initial response when I suggested it was that this makes a lot of sense. It was a very positive response. So it's certainly something worth pursuing. It seems promising. Another point involves continuity of coverage and care. Many of you may have seen this very worrisome study that came out in Health Affairs just a month or two ago, finding that if you set the transition point between Medicaid and the exchange at 133% of the federal poverty level, which is where the federal law sets it, then for more than 35% of low-income adults, they're going to be bouncing back and forth between Medicaid and the exchange at least once every 6 months. That's not a very continuous system of coverage and care. If instead you move the transition point from 133 to 200% FPL, there would be many fewer people who would have to make that transition. And that's so for two reasons. One, there are a lot more people who are going to get subsidies at around 133% FPL than at 200% FPL. The higher your income goes, the more likely you are to be offered employer-sponsored insurance and therefore to be ineligible for subsidies. But second, income bounces around a lot more at lower income levels. It's because, you have a lot of shifting and contingent employment arrangements, much more unstable. The higher income goes, the less instability one sees. So therefore, implementing BHP to cover people with one set of plans all the way up to 200% FPL could greatly reduce discontinuities of coverage and care. That has clinically significant consequences. We know if you can keep seeing the same doctor over time, your health outcomes tend to be better in many cases. Administrative costs could be much lower. If you bounce back and forth between Medicaid and the exchange, and at each turn of the wheel, at each bounce of your progression, public entities have to determine your eligibility and sort you into a plan and give you a chance to choose a plan and do default enrollment. That's a significant administrative cost that you avoid if there's continuity of coverage and care. And finally, if I as an insurance company know that you as a consumer may not be around in 6 months to a year, it reduces my incentive to invest in your long-term wellness. Whereas if I know there's a good chance you're going to be with me on into the future, well, then I have much more of an incentive to invest in how you'll be doing next year or the following year. Now, the big disadvantage of BHP, obviously, involves provider payment rates and therefore provider networks. With Medicaid in most of the country, you have much lower provider payment rates for many categories of providers, therefore much less access to care. Now, if the BHP federal dollars exceed the baseline Medicaid costs, then the most logical way to use that access would be to raise the provider payment rate. So that would be that would lessen this problem somewhat. But to be honest, you still would be looking in most states at a much lower level of provider payment, which providers are not going to like, and a reduced access to providers. So the question facing policymakers who care about consumers more than anything else is, for this particular group of near poor adults, what is more important in securing access to care? Keeping costs low, out-of-pocket costs and premium costs low, or providing access to a broader network of providers that's enabled by higher provider payment rates? That's the question that people can ask. Now, there's also an issue about what kinds of health plans you get. If you're enrolled in a Medicaid look-alike program or a CHIP-like program, then you may lose access to some commercial coverage. On the other hand, you would retain access to safety net plans, many of which have an expertise in serving low-income populations, and those plans may or may not be available in the exchange, depending on how things play out in your individual state. So there are going to be implications for health plan choices either way. Let's see, trying to click ahead. Have I lost my mouse rights? Let's see, trying to click ahead. Is that, did we miss everything? Let's see, is there anything else? Okay, there we go. All right, so in conclusion, if you implement BHP to build on the existing systems of Medicaid and CHIP coverage, you could make a significant improvement in affordability of coverage and care for low-income consumers. You may wind up saving a fair bit of money on your state Medicaid program, and doing so without increasing costs or taking away benefits from currently eligible consumers. The biggest trade-off for consumers is that provider networks will be smaller because payment rates will be lower in a Medicaid-based product than in a private insurance plan. And it's going to be important to see how the federal government interprets this statute and to look at the circumstances in the individual states. I've described what's happening in the country as a whole as we see it, but circumstances will vary a lot by state. And I put up here on this slide a link to the paper that I was fortunate enough to be able to do for Academy Health that talks through these issues in some detail. So now, in the remaining 15 minutes of our webinar, I would be delighted to take any questions.
Well, great. Stan, thank you very, very much. I'm actually going to take the prerogative to just ask you to clarify a couple of things.
Sure.
On your slide number 4, you talked about actuarial value.
Yes.
Now, that doesn't mean that somebody at 150% of the poverty level automatically gets 94% of their costs. If somebody had chronic illnesses, that's across the entire population, right?
Right. The actuarial value is a measure of the comprehensiveness of a given package of benefits and out-of-pocket cost sharing. So, I gave a couple of examples. And the way you test it is you say, if everybody in America were enrolled in this plan, what percentage of everybody's health care costs will be paid by this insurance plan? So, but you're absolutely right. For some people, the plan may wind up spending a lot more than that percentage. For other people, a lot less. It's just a way to gauge the overall comprehensiveness of a given package of benefits.
Right. So even if we look at that and say, well, that's not so bad, it's paying quite a bit, for some people it could be a lot higher.
Right, and that's why I gave you the examples of those benefit packages where, for somebody at 175% FPL, they'll get coverage with an 87% actuarial value. And what that means in the real world is $250 deductible, and you have to pay, 25% of the cost of prescription drugs. That's how it works today with a very popular plan at 87% FPL. So the question would be, for a low-income, low-wage working adult, what's the effect of a $250 deductible? What's the effect of a 25% prescription drug copay? Well, we know from the literature that a lot of people won't enroll, and even if they do enroll, a lot of people are not going to use services. Right,
and if a state did the BHP option, they could be put into something similar to the Medicaid plan they're in now. Those parents who are covered in pregnant women, and
exactly.
They wouldn't have those costs. When you talked about, I always learn new things when I talk to you, Stan. In terms of the policy issue around the tax credits being pegged to the cost of the reference plan, this was on slide 15. And you talked about if that reference plan is a very inexpensive Medicaid plan, which I think is unlikely, but suppose it is, the BHP amounts would fall. Can states change their mind about the BHP option if, in fact, that ends up happening?
Well, here's how it works. A state gets paid, suppose a state decides just to step up for a minute, the state decisions to implement BHP will proceed on a year-by-year basis. So the federal government will provide the state what it thinks is the BHP amount before the year begins, and after the first year ends, if there's any excess or any insufficiency in federal funding relative to what it should have been, that will be made up for in the following year.
Okay. I think I've got a beat on it. And also, I know everybody's going to be very interested in this one on number 16, so I'm actually going to go back to that slide. The state cost savings. Now, the first option, the first source of savings, that happens whether states choose the BHP or not.
Correct.
The second is only if you choose the BHP. Is that right?
No, that's not quite right. The first is whether you choose BHP or whether you eliminate Medicaid for these folks and put them into the exchange. But to be clear, the only way to eliminate Medicaid for these folks and preserve their existing affordability of coverage is via BHP. Mm-hmm. If you achieve the savings by eliminating Medicaid and moving them into the exchange, well, you don't get any extra savings, but you impose increased costs on these adults. So that's the first point. The second point with medically needed coverage, the state will experience significant savings either way because we're talking about people who are otherwise uninsured today receiving comprehensive coverage. However, if the state implements BHP, it could get extra savings in this category by structuring coverage to further delay the point at which spend down is met. So you'll save money either way in the second category, but you could potentially save more with BHP.
So you could have fewer people coming into Medicaid where you have to match through the medically needy channel, right?
Precisely.
Okay. And the last one, is that dependent on choosing the BHP option?
No. Either way, though again, the only way is, like suppose you're a state that today provides some very poor immigrants with Medicaid, even though they're recently arrived in the country. You could say, we're going to kick you off Medicaid and put you into the exchange, and we're going to save money on you. But that means these folks are going to have to pay more than $50 a month in premiums, which we know many are not. They're going to get coverage with $45 prescription drug copays, which means they're not going to fill their prescriptions. So if you want to save the money that you're spending on these potentially very poor, legally present immigrants, and if you want to save that money without exposing them to unaffordable costs, BHP would be the way to do that.
Right. Okay, I think I'm getting a beat on this now. And my last question, and then I'll let somebody else ask one, is where you talk about access to providers
Yes.
and plans that, I mean, this is going to be an issue for states, and I know a lot of the policymakers in the Eastern region are very concerned about Medicaid access, whether or not they do BHP.
Right.
There's going to be millions of people coming into Medicaid, and this
Right.
is a program that's already struggling with provider
Exactly.
participation. And I think the BHP option, I mean, you said it, but I think we should overemphasize this, that the BHP option, if there is an excess of funds, can be used to raise rates for providers, particularly, and it has to be used for people in the BHP program, which is going to be mainly adults. And adult medicine is where the lowest rates are and the worst participation rates are. While it's a different, it's funding to go to the BHP patient, those rates, if there are overlapping panels, and chances are there would be, that can help attract more providers into Medicaid.
Yeah,
Have I got that right?
Absolutely.
Okay, cool. All right, well, I will shut up now and see if Betsy or Paula have any questions.
Go ahead, Paula. Are you there?
Yep, we can hear you.
Okay, well, this is Betsy, and I have a couple questions, but I thought Paula was going ahead, so.
No, go ahead, Betsy, because I'm looking for my question.
Okay. A couple of them Ellen touched on a little bit, but I wanted to make sure exactly I understood it. And so maybe to go back to the discussion about the medically needy and the issues around savings with BHP that could accrue through a slower spend down, particularly. And I didn't know, Stan, if there's any information out there that maybe could give us some clues as to how that would be realized, the speed at which it could be realized, or the impact. Because, and like many states, I'm sure, we struggle with this. Yeah. And the potential in my state, in Connecticut, is huge. There's enormous potential there. And so I wondered if there are any keys to sort of quantifying that for us.
We have not gone through that effort. I'm not sure how exactly we would. I guess what you would need to do in a state would be to look at the administrative data you have about who your medically needy folks are, how they spend down, what they spend down on, and then once you have that data, you could you could go through and say, well, let's suppose they get coverage with an actuarial value of whatever would apply, 87% and so forth. What would that do to their claims, and how soon they would spend down? And now let's say what happens if they get coverage where there's a Medicaid style out-of-pocket cost sharing, which in Connecticut would mean nothing. Then you would say, well, what happens to their spend down? So I think the way to do it would be to look at state administrative data.
Okay, yeah, and I agree that would be pretty complicated, but yep. I think that would be very interesting information, particularly, and you said, a state like this one, where also at the same time we're experiencing very strong resistance from providers, mostly the hospitals, about taking the BHP route for right. Many of the reasons that you mentioned, that never talk about the opportunity for some costs to come back to us that could be used in a different way, ultimately, to help them out. And I think those are points, the tipping point in those discussions, I guess, is still very evasive to me. I feel ill-equipped to sort of push back to some of those yet, in the absence of maybe more quantified information.
Well, you know, one thing to think about in that context is that the big picture for hospitals is not going to be affected by basic health implementation significantly. The big picture for hospitals is there are going to be a lot fewer uninsured people coming to their doors, and therefore they're going to get more money on them, whether it's Medicaid or private insurance. There will be a significant increase in Medicaid coverage, and there will be a moderate increase in private insurance coverage. And so in Connecticut, for example, we did an analysis, and what we found was that you'd have, you know, it would affect 1% of the state population. Instead of a 6% increase in private insurance coverage, it would be a 5% increase in private insurance coverage. Instead of a 10 percentage point increase in Medicaid, it would be a 9 percentage point increase in Medicaid. So it's something. It's definitely money, but it's not monumental in impact.
Well,
I don't know if that's helpful.
It's helpful to understand that. It's some of the pushback, of course, and you've heard all of this.
Sure.
But, and it'll be interesting from other states as well, because Connecticut is a high-cost state with a very poor Medicaid reimbursement rate, and historically that has definitely been the case. Yeah. So the pushback from the hospitals is that that's still, there's the incentive to change that. They just aren't ready to buy in at all, that that's what's going to happen for them, and that instead the devastating impact, or potential at least, for bringing a much greater proportion of their payers down to the Medicaid rate is it's, you know, too horrifying for them to be able to sort of contemplate right now. Yeah. And consequently, you know, they're going to push back hard.
Right.
And maybe some other participants actually have some different experience or some different points to lend on this.
Great. Well, Paula, did you have a question?
Well, I wanted to probe on a couple of things, a little bit on the, you know, the Medicaid look like and how you really build this into Medicaid, because I'm assuming that the benefit package in a BHP is not as rich as Medicaid. So I'm just, you know, as basic as that is, I'm still trying to wrap my head around that.
Sure. So from the, here's how it would work. From the consumer's perspective, so let's suppose you decided to do, well, here's how it's being discussed in Connecticut as an example. There's legislation pending that would say we're going to do Medicaid up to 200% of the federal poverty level for all adults, and we're going to fund it using BHP. So from the consumer's perspective, it doesn't matter whether I'm at 70% FPL or 170% FPL. I'm in the Medicaid program. I have nominal co-payments and premiums. So on the back end, how does it work? Well, if I'm under 133% of the federal poverty level, then I will qualify for Medicaid match, which in Connecticut would be 50% FPL. I'm not sure what it is in Delaware, whatever it is.
Right.
And then, but above 133% FPL, what I would get is the BHP money. So what is the BHP money? It's 95% of what the feds would have spent on subsidies in the exchange. Now, and that amount nationally is going to be higher by 29% than what Medicaid costs would be. And the reason why is that although the coverage in the exchange has higher cost sharing, it also has much higher provider payments.
Oh, okay.
And so therefore 95% of the BHP subsidy on average is going to be significantly more than the full Medicaid cost of taking care of these folks.
Okay. And then I guess the other thing is, you know, there are some states in the Northeast like us that, you know, just have a low population base.
Yeah.
And we are already worried about whether we have enough numbers to make an exchange work as it is. So, I just wonder if that, when you look at these options, are you assuming a larger state population than, like, fewer than 1 million people?
Well, you know, it's an interesting question. And and that sort of begs the further. So in other words, what I hear from you is, okay, suppose it's just 2% of Delaware's population, or 1% that we're talking about. That still could make a difference.
Right.
You know, just the total absolute number of lives is sufficiently small that the difference between 16% and 14% of non-elderly residents is significant. A couple things to keep in mind. One is that in the old days, people would talk about how there needs to be at least 100,000 covered lives in the exchange for it to be viable. And the reason why was that risk wasn't pooled between the exchange and the rest of the individual market. So so each exchange plan had to stand or fall on its own. So if, you know, I'm covering 400 people inside the exchange and one of them gets really sick, well, I, the insurance company, am really up the creek. But under the Affordable Care Act, risk is shared between the exchange and the rest of the individual market. So if I have 400 people in the exchange and I have 2,000 people outside the exchange who I'm covering as an insurance company, then all right, somebody gets sick, somebody goes in the hospital, it's not going to have a big effect on me because they're all pooled together. Plus, there are these reinsurance mechanisms and these risk adjustment mechanisms that further pool risk. So it's not just even beyond the individual, beyond a single insurance company, it's all the individual market that is pulled together if these mechanisms succeed. So what that means is that an exchange doesn't need to be as big as it used to need to be in order for it to be viable. Now, that's all sort of theoretical. I can give you a real-world example. In Massachusetts, their commercial exchange is the Commonwealth Choice program for people over 300% of the federal poverty level, and it covers, I think, fewer than 20,000 people, maybe 20, 30,000 people tops. And it's, you know, it has not changed the world in the way that people had hoped it would. Hasn't revolutionized delivery systems. It's brought down premiums some, but it's certainly stable, and it's been growing over time because Massachusetts has implemented the same kinds of mechanisms for pooling risk across the entire individual market. So I think in the new world, as illustrated by Massachusetts, absolute size does not need to be as big as it used to be. The other thing to keep in mind in the new world is that the only place individuals can get subsidies is the exchange. The only place small firms can get tax credits is in the exchange. So there's going to be a level of glue that keeps people to the exchange that we never saw before.
Right.
We, Paula, I
Yep,
didn't want to cut you off. Okay.
Yep.
We have Barbara Galrin has raised her hand, but she needs to input her audio pin for me to be able to unmute her. In the meantime, she put in a couple of questions in question pane. Are you using BHP and Exchange synonymously? And please clarify Exchange.
Sure. So the exchange is under the Affordable Care Act, each state's residents will be served by a health insurance exchange, which will be a convenient place for individuals to shop and small firms to shop. And you go on the exchange and you can choose from among all kinds of different insurance options. That's how the exchange works. And as I just indicated, it's the only place that individuals can use their tax credits. It's the only place that small firms can use their tax credits. And so if you implement BHP, what you do is you say for adults with incomes too high for Medicaid but below 200% of the federal poverty level, they're not going to be in the exchange anymore. They're going to go into the basic health program. And the state is going to contract with providers or with health plans to furnish them with coverage. So, and that means that the state can't hurt these consumers. It can't give them less generous coverage than they would get in the exchange, but it could provide more generous coverage. And that's what we've been talking about in this webinar.
Well, great. It sounds like that answered her question, even though she's having audio problems. So I think since I'm not seeing any other questions, I want to thank Stan. And as I said, the slides will be up on www.csgeast.org. And Stan was kind enough to put his contact information on the slide, so he will be sorry he did that. If you have more questions, you can ask.
Absolutely.
Thanks a lot.
Thank you all.
Thanks.